Med-Surg students, I'm going to go over cirrhosis. And cirrhosis is one of those conditions, and mostly I'm going to be talking about end-stage cirrhosis, but cirrhosis is one of those conditions where it affects all body areas, right? From neuro to cardiovascular, hematological, it's going to affect everything, okay? Now, and that has to do with the functions of the liver. I'm not going to get so much into the carb metabolism, but the protein metabolism. The liver makes non-essential amino acids. It synthesizes plasma proteins, which are also gamma globulins. So the patient with liver disease is going to be more at risk for infection. It synthesizes clotting factors. So the patient with liver disease is going to be at risk for bleeding, and it synthesizes urea from pneumonia. When the liver can no longer do that, the ammonia travels in the bloodstream and it crosses the blood-brain barrier, and it makes patients become very confused. That high ammonia level makes patients become very confused. They get what's called encephalopathy, and we'll go into great detail about that. I'm not really going to talk about the fat metabolism, but detoxification. The liver can no longer break down harmful toxins and hormones. Okay, so let me just preface this by saying cirrhosis, somebody can have cirrhosis for like 20 years and not even know it. They go to the doctor one time and they might have like a low platelet level, and they start to look into it and they're like, you have cirrhosis, because it can be compensated for like 30 years. And then they go into what is called a decompensated period, where we start to see all these complications of cirrhosis, okay? So the first complication I'm going to talk about is portal systemic encephalopathy. And we would see this in end-stage cirrhosis. And just so you know, encephalopathy, there are 4 different stages. And it's not important that you know the different stages, like what happens in each stage. But what I want you to know is, if your patient has any of the signs and symptoms of encephalopathy, that is a priority, because say they're in stage 4, they can get the treatment, the lactulose, and they can go back to level 1. That's why we have to, report that to a provider right away so we can get them the treatment they need. So encephalopathy, I told you they go back and forth through 4 stages. What causes it? It's caused because the liver can't detoxify ammonia. And other factors that might lead to it is a high protein diet, because when you eat a high protein diet, your BUN goes up and the liver can't break it down. Okay, so ammonia circulates in the bloodstream and it makes them crazy. Um, uh, Infection, GI bleeding. Okay, patients with cirrhosis are at risk for GI bleeding because they have something called portal hypertension, where they get varices in their esophagus. Now, you can think of a varice kind of like a hemorrhoid, but on the esophagus, okay? It's 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 like the veins have been becoming engorged. And so when they bleed from these, they're going to swallow the blood, and the blood is digested as a protein. So after an episode of GI bleeding, they're going to be really prone to encephalopathy. Um, the signs and symptoms. Okay, this is classic. Altered sleep-wake cycle. Your patient's going to say, I'm awake all night and I want to sleep all day. They have hand tremors and asterystics. And right here I have a little video of what asterystics looks like. It's called like liver flapping. So it's like the wrist in the hands flap. Okay. They're going to be confused. They can't concentrate, and they may have that musty liver breath. So if your patient has any of these, this should get your attention, because you can bring it back down a level with the right treatment. So you would expect them to have high ammonia in end-stage liver disease, and we want to try to mitigate that by giving lactulose and getting the ammonia down. Okay, so your interventions include giving the lactulose. Monitor the potassium, because as patients get lactulose, they may have frequent stools. Assess for the changes of LOC. Report fetor, asterystics, and confusion. They are going to need a low protein diet to prevent confusion. That's why they're on it. Now, I did mention that cirrhosis affects everything. Okay, so neurologically, we kind of talked about that. Their skin is going to become jaundiced because as the liver fibroses, it cuts off the bile channels in the liver. And then, so the bile, so to speak, bile salts are going to leak into the skin, so there'll be jaundice. They get spider angiomas because they can't detoxify estrogen. They get palmar erythema because of the estrogen that's circulating in their blood. Purpura and petechiae are due because they're at risk for bleeding because of two reasons. Number one, the liver can no longer manufacture clotting factors, so that's one reason. The other reason is the spleen gets very inflamed, okay? And it acts like a Pac-Man, and it eats all the blood cells. So it eats the red blood cells, it eats the thrombocytes, and it eats the white blood cells. Caput medusae is due to portal hypertension, and what that means is snakes on the belly. Okay, so the veins are going to get very tortuous and distended on the belly, and I have another picture of that. Cardiovascular, they're going to have ascites, which is an abdomen full of fluid, so to speak. Okay, so what they would do with that is put the patient on a low sodium diet. They would be on diuretics, and you would have to monitor weight and measure their abdominal girth each day, okay, or each shift, I should say. Daily weights is another thing you would do. For GI, I talked about the esophageal and gastric varices. And then reproductively, they are going to have problems with reproduction. All right, so I talked about that's why they have jaundice, because they have decreased excretion of bilirubin to the small intestine. The serum bilirubin are going to be elevated. They're going to have pruritus because of the accumulation of bile salts. What you need to remember is that never use hot water, use tepid water. Don't use strong soap, and then pat dry their skin. All right. Splenomegaly, I already talked about this. It causes the pancytopenia. That puts them at risk. They have leukopenia for infection, anemia. They're going to be fatigued, have tachycardia, etc. Thrombocytopenia puts them at risk for injury due to bleeding. They're at risk for bleeding for the two reasons I already told you. So the treatment, if they need it, would be vitamin K and FFP. FFP, fresh frozen plasma, contains all the clotting factors. So if somebody is actively bleeding, you're probably going to go with FFP first because they can get those clotting factors right away. Then you would give your vitamin K. Signs and symptoms of bleeding, the petechiae, ecchymosis, nosebleeds, vomiting blood, tarry stools. These are the interventions. This is important. You have to know what to do when somebody's on bleeding precautions, right? They need a soft toothbrush because you don't want their gums to bleed. Although I've never taken care of anybody who has died from bleeding gums, it's just a mess. Minimize needle sticks. So you want to be careful about putting in IVs. Use a 22 gauge. Use the smallest gauge possible. You never want to give IM injections to somebody that has bleeding tendencies. They need to be on stool softeners because they're going to have hemorrhoids and you don't want them to bleed rectally. And they need an electric razor. Nothing per rectum. Don't take a temperature per rectum. Nothing per rectum. And firm footwear. Okay, and that's so they don't fall. The findings you would find due to the estrogen effects, the spider angiomas I talked about, the male pubic hair shape becomes triangular. Normally it's diamond shape, and you can check that later. Palmar erythema is red, warm hands, and then, of course, the sexual problems. Men will have gynecomastia. All right, the labs. Early, the LFTs are going to be elevated because they're the troponins of the liver. But what happens over time? As the liver fibroses more, it can no longer release those enzymes. So they'll have a prolonged PTINR because the liver cannot make the clotting factors. They'll have an increased ammonia because the liver can't detoxify it. They'll have an increased bilirubin because the bile channels in the liver are going to be constricted, and maybe they'll have a high glucose. So the labs that you expect to be low are albumin because the liver cannot make clotting factors, platelets because the spleen is eating them up, white blood cell count because the spleen is eating them up, low hematocrit because the spleen is eating them up, and low protein because the liver can no longer manufacture protein. Okay, so the protein levels are decreased. All right. Liver biopsy. This is the most definitive way to diagnose liver disease. So what you need to know, obviously, it's an invasive procedure, so do your consent. And then when the provider's doing it, you're going to have the patient exhale and hold their breath for 10 seconds during the biopsy. That's so the provider doesn't puncture the lungs, so they don't get a pneumothorax. Monitor for bleeding and keep the patient on their right side. I've taken care of somebody who has died after a liver biopsy because she was already prone to bleeding and they didn't put her on her right side after. You have to put them on their right side so it will tamponade the bleeding. Remember that. That's really important. Nursing interventions. Okay. So you want to keep the head elevated because patients often have a big belly, and I haven't talked about that yet, but they get what's called ascites, so they have difficulty breathing, so you want the head of the bed up. Restrict fluid and sodium as ordered. Now, fluid restriction is for people circling the drain, but definitely a sodium restriction for cirrhosis just to decrease ascites. And they'll be on diuretics. Okay. The best way to determine fluid balance is daily weights. You always want to ask somebody with a drinking problem when their last drink is because you don't want them to go into the DTs. You need to get them on the prophylaxis right away. Now I'm going to talk about something called portal hypertension. Because the liver is so fibrotic, right? Normally the portal vein comes into the liver, but it's got to push up against the fibrotic liver. So because of that, the veins make all these collateral channels. So the patient's going to have esophageal varices. They'll get caput medusae. They'll have hemorrhoids. So that's what usually happens. They may have like some in their abdomen as well. So because of that, they're going to end up with ascites. They'll have caput medusae, hemorrhoids, varices, which can kill them if they bleed, hepatic encephalopathy, which we talked about, splenomegaly, which we already talked about, the spleen acting as a Pac-Man. Okay, so this is what caput medusae looks like. See those tortuous veins? It's like varicose veins in the stomach. This is what ascites looks like. Remember, they need to go on a low sodium diet. You would measure the abdominal girth around the umbilical and low sodium diet, diuretics, and possible fluid restriction. Possible, maybe. Okay. They may get, because see how big this is, sometimes they get really short of breath when their ascites gets this big. So they may have a paracentesis. The important thing about a paracentesis is they have to empty their bladder before they have it. And they take off a lot of fluid, so you're going to be monitoring for shock after. And we haven't done shock, but at the end of the semester, you'll learn more about shock. If for the nursing interventions to prevent or manage hemorrhage from varices, esophageal varices, this is important. All patients in cirrhosis need to be screened for varices in the endoscopy lab. They'll be put on a non-selective beta blocker such as propranolol. There are two medications they can be given to treat the varices. One is called octreotide and one is called vasopressin. Octreotide can be given to anybody, but vasopressin cannot be given to people with a history of coronary artery disease. So think of people that have had an MI, people with CAD. So you're going to have to kind of, you need to look at the history before you start one of those medications. They go to endoscopy lab and that's how the varices are treated. And I already talked about the blood being digested as protein, so it's going to lead to PSE. So make sure you understand the difference between octreotide and vasopressin. So you're going to be looking for dysrhythmias if somebody's on vasopressin and chest pain. But you certainly wouldn't want to give it to anybody that has a history. Okay, now let's go into the other liver condition we're going to talk about, and that's hepatitis. So one of the good things is there's 5 different types of hepatitis. There may be more now, but we're only going to focus on A, B, and C because those are the most prevalent types in the United States. So hepatitis is inflammation of the liver. Usually it's a viral infection. So the liver is going to become very inflamed and patients are going to have pain in the right upper quadrant because of it. A lot of times people with hepatitis can be asymptomatic and they don't even know they're contagious, which is why we have a problem with it in our country. So Hep A is transmitted through fecal oral methods. And how I remember that is A is for a very naughty word that I'm not going to say in case your kids are in the room. Okay? And here are some examples. Person to person, oral to anal activity, contaminated water or milk, uncooked shellfish, and also like contaminated fruits and vegetables if somebody is traveling. There's no medication that treats Hep A. Hep A is self-limiting. Sometimes people think they just have the flu. Now there is prophylaxis, so immune globulin for Hep A and B. Hep A and B also have vaccines. C does not have immunoglobulin or a vaccine. So children and young adults are most prone to hepatitis A. Anybody that gets hepatitis should no longer have sexual activity. So to prevent hepatitis, you're going to tell your patients to have safe sex. Once they get it, they cannot have sex until the antibody titer comes back negative, or the antibody screen. They can't share personal items. And having either hepatitis A or hepatitis B is going to result in lifelong immunity. However, that's not true for hepatitis C because there's so many different strains. Hep B is transmitted through blood and body fluids. So how I remember that is it's transferred through blood and booty fluids. So blood, semen, vaginal fluids. So blood, but not sweat and tears, urine or feces for B and C. All right, so somebody with Hep B is going to put on standard procedures. The people that are at risk are people that have received blood, not so more in our country anymore, but infected saliva or semen or vaginal fluid, okay? Contaminated needles, those are ways it can be transmitted. So the incubation period for Hep B is 6 months long. So in other words, something they get it, they don't have symptoms for 6 months, and that's a problem. So in Hep B health promotion, you want to tell people to have protected sex, not to share needles, don't have sex with infected people, and complete the Hep B vaccination series. So who's at risk? IV drug users, college students, people with multiple sex partners, sex workers. Mode for transmission in Hep C is basically the same as Hep B. Okay, so you can kind of put them into the same category. Hep B and C can turn into cirrhosis and liver cancer. Now, there are early symptoms, we call those prodromal symptoms of hepatitis. Now, the good thing about hepatitis is A, B, and C all have the same signs and symptoms, okay? So you just have to know the little difference between the transmission for each one. So the prodromal symptoms include fatigue, anorexia, nausea, abdominal pain in the right upper quadrant usually, and joint pain. So kind of like you're getting the flu. And then what you'll see is jaundice and icterus. Icterus is yellowing of the sclera of the eye. I talked about the joint pain being early and muscle pain. Diarrhea and constipations. They're going to have changes in the color of their urine. It'll be dark, foamy, or frothy, and their stool may become clay colored. They'll have a fever, lethargy, malaise, nausea, and vomiting, and itching. All right. GI symptoms are going to be VAN, so vomiting, anorexia, and nausea, and clay colored stools. So the pain is going to be in the right upper quadrant. And patients with hepatitis need to abstain from sex until they clear the virus. So some of your nursing interventions, they are going to need a high carb, high calorie, moderate fat protein diet. So small frequent meals, no alcohol. So people with hepatitis cannot drink sometimes even after they're healed. The physician is very strict about this because it can damage the liver. For rest, you're going to have them alternate periods of rest with activity. Make sure people are washing their hands. If you ever get a needle stick, make sure you wash your hands very quickly before you even go to your policy for needle sticks. I told you about the diet already, and it can turn into liver cancer, and it can turn into cirrhosis. So that's it for hepatitis for your liver review on Quizlet.